Hi there, our highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. This video I am about to present was compiled by Dr. Nath Arua, a clinical pharmacist by training and profession who is the founder of Progressive Pharmacotherapy Consultants, the premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management and optimal clinical outcomes are very crucial and non-negotiable to us. Here we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, on behalf of the Institute, I humbly urge you all to sit back and spare me part of your very precious time to share with you very useful tips which may prove very, very handy in your line of duty. I now welcome you all to part 171 of our Pharmacotherapy MCQ series, which majors in infectious diseases. And the first question reads, GRL, a 25-year-old male patient weighing 98 kilograms, is diagnosed with active tuberculosis TB. He has no relevant past medical history. Currently he takes no medications. He is allergic to codeine. His pertinent labs include a creatinine clearance of 94 milliliters per minute per 1.73 meters squared. His liver function tests are within normal limits. So my question to you is, which of the regimens listed below would be the most appropriate treatment regimen for GRL now? Would it be A. Isoniazid plus rifampin plus pyrazinamide plus ethambutol twice weekly for 9 months, or B. Isoniazid plus rifampin plus pyrazinamide plus ethambutol daily for 6 months, or C. Isoniazid plus rifampin plus pyrazinamide plus ethambutol daily for 4 months, followed by isoniazid plus rifampin daily for a 2-month continuation phase, or would it be D. Isoniazid plus rifampin plus pyrazinamide plus ethambutol daily for 2 months, followed by isoniazid plus rifampin daily for a 4-month continuation phase? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is D. Isoniazid plus rifampin plus pyrazinamide plus ethambutol daily for 2 months, followed by isoniazid plus rifampin daily for a 4-month continuation phase. The patient has no underlying reasons for not receiving the preferred treatment regimen of rifampin, isoniazid, pyrazinamide, and ethambutol for a 2-month intensive phase, followed by a 4-month continuation phase consisting of rifampin and isoniazid, making answer D correct. Answer C is incorrect because it states a 4-month intensive phase and a 2-month continuation phase. Answer B is incorrect because it is all 4 medications for 6 months. Answer A is incorrect because it is using all 4 medications for 9 months, as well as being twice weekly. Please advance to the next question. And the next question reads, which of the following regimens would be most appropriate during the continuation phase for treating a 75 kg patient co-infected with pulmonary TB and HIV, who is not taking any antiretrovirals for treatment of HIV? Would it be A. rifampin 600 mg and isoniazid 300 mg daily, or B. rifapentine 600 mg and isoniazid 900 mg once weekly, or C. rifabutin 300 mg and isoniazid 900 twice weekly, or would it be D. rifampin 600 mg and isoniazid 900 mg twice weekly? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is A. Rifampin 600 mg and isoniazid 300 mg daily. Intermittent TB treatment, that is once weekly, twice weekly or thrice weekly dosing, treatment may be considered in several cases, particularly if a patient is at low risk of relapse and HIV negative. Twice-weekly therapy of rifampin and isoniazid is not recommended in co-infected patients due to an increased risk of rifamycin resistance, making answer D incorrect. Rifabutin, while often substituted for rifampin in co-infected patients, is not recommended twice weekly either for the same reasons, making answer C incorrect. Rifapentine and isoniazid once weekly are not recommended in patients with HIV, making answer B incorrect. Daily treatment with either rifampin or rifabutin and isoniazid is recommended to avoid recurrent disease and rifamycin resistance, making answer A the correct choice. Note: in the event a co-infected patient does not receive antiretroviral treatment for HIV, a continuation phase of 7 months is recommended over 4 months for drug-susceptible pulmonary TB. Please advance to the next question. And the next question reads, LGT, is a 36-year-old male nurse with a positive tuberculin skin test of greater than 5 mm. A T-spot test confirms he has latent tuberculosis infection, abbreviated as LTBI. He has a past medical history significant for hypertension. His current medications include lisinopril 5 mg and ibuprofen for occasional muscle aches. LGT is healthy and would like to begin treatment for LTBI, so my question to you is, which of the regimens listed below would be most appropriate for LGT? Would it be A. Rifapentine 600 mg plus isoniazid 300 mg once weekly for 3 months, or B. Rifampin 600 mg plus pyrazinamide for 2 months, or C. Isoniazid 300 mg for 9 months, or would it be D. Rifampin 600 mg for 9 months? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is C. Isoniazid 300 mg for 9 months. The preferred treatment option for LTBI is isoniazid 300 mg daily for 9 months, making answer C correct and answer A incorrect. This patient has no factors that would warrant his trying another regimen such as rifampin, making answers D and B incorrect. Rifampin and pyrazinamide is no longer recommended because of an increased risk of hepatotoxicity, making answer B incorrect. Please proceed to the next question. And the next question reads, LGT returns to the TB clinic 7 days later, stating that he had a bad reaction to isoniazid with a severe case of hives and refuses to take it again. So my question to you is, which of the regimens listed below would be most appropriate for LGT in this clinical scenario? Would it be A. Change to rifapentine 600 mg and isoniazid 300 mg once weekly for 3 months, or B. Change to rifampin 600 mg and pyrazinamide for 2 months, or C. Continue isoniazid 300 mg twice weekly for 9 months, or would it be D. Change to rifampin 600 mg daily for 4 months? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is D. Change to rifampin 600 mg daily for 4 months. This patient had a reaction to isoniazid, therefore, a reasonable alternative would be treatment with rifampin for 4 months, making answer D correct. Rifampin has several drug interactions, and the patient must be cautioned not to begin any new medications without first determining whether rifampin will interact. The patient only takes the Cinepril and occasionally ibuprofen, which is not an issue. Using an intermittent regimen containing isoniazid, answers C and A, would not help with the reaction. In addition, the dosing is incorrect. Answer B is incorrect because of the increased risk of hepatotoxicity with rifampin and pyrazinamide. Please progress to the next question. And the next question reads, TRM, is a 28-year-old male patient being treated for multi-drug-resistant tuberculosis, abbreviated as MDR-TB, for the past 60 days. His current medications include a daily regimen of pyrazinamide 2000 mg, moxifloxacin 400 mg, cycloserine 500 mg, para-aminosalicylic acid, and amikacin. His most recent labs showed an increase in his serum creatinine and a declining renal function, that is his creatinine clearance, CrCl is 55 ml per minute. TRM complains of dizziness, lethargy, and inability to concentrate. So my question to you is, which of TRM's TB medications most needs to be dose adjusted now? Is it A. para-aminosalicylic acid, or B. cycloserine, or C. pyrazinamide, or is it D. moxifloxacin? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is B. cycloserine. Because the patient's renal function is declining, any medications eliminated renally may need to be adjusted. Cycloserine concentrations should be monitored and dose adjusted, if necessary, to maintain serum concentrations below 30 mcg per milliliter. Moxifloxacin has been associated with CNS adverse effects, however, because of the timing of the adverse effects in conjunction with declining renal function, the adverse effects are more likely to be associated with cycloserine, making answer B correct and answer D incorrect. Para-aminosalicylic acid is metabolized in the liver and not renally adjusted, therefore answer A is incorrect. Pyrazinamide is metabolized in the liver, its metabolites can accumulate in renal insufficiency, however, dosage adjustment is not needed unless CrCl is less than 30 ml per minute, making answer C incorrect. Please advance to the next question. And the next question reads, TAW, a 25-year-old HIV-positive male patient presents to the clinic with a positive tuberculin skin test, negative chest radiography, and no clinical signs or symptoms. An interferon gamma release assay confirms LTBI. He is keen on taking the 12-dose regimen he has heard about, which consists of rifapentine and isoniazid. He is not receiving highly active antiretroviral therapy at this time but also seeks to begin that as well. TAW takes no other medications. His labs are within normal limits. So my question to you is, which of the recommended HAART regimens listed below would be the most appropriate if TAW were to be treated with rifapentine and isoniazid for 12 weeks? Would it be A. darunavir boosted with ritonavir once daily plus tenofovir co-formulated with emtricitabine once daily, or B. Elvitegravir boosted with Cobi-C-Stat plus tenofovir co-formulated with emtricitabine once daily, or C. Raltegravir twice daily plus tenofovir co-formulated with emtricitabine once daily, or would it be D. Dolutegravir once daily plus tenofovir co-formulated with emtricitabine once daily? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is C. Raltegravir twice daily plus tenofovir co-formulated with emtricitabine once daily. Drug interactions with rifampicin and many of the antiretrovirals have not been studied. Rifampicin is as potent an inducer, or almost as potent, as rifampin, however, and the potential effect on an antiretroviral used in conjunction with rifampicin is extrapolated. Rifampin reduces dolutegravir's AUC by 54% and its minimum concentration, Cmin, by 72%. If used concurrently, dolutegravir should be administered twice daily rather than once daily, making answer D incorrect. Elvitegravir, a CYP3A substrate, is expected to have its concentrations greatly reduced by rifampin and rifampicin and should not be co-administered, making answer B incorrect. Although studies have not examined rifapintine's impact on darunavir concentrations, darunavir's concentrations are significantly decreased by rifampin, and it is not recommended. That makes answer A incorrect. Rifampicin once weekly actually increases raltegravir's AUC by 71% and decreasing its Cmin by 12%, but raltegravir's safety profile is not expected to have a significant impact clinically, making answer C correct. Please proceed to the next question. And the next question reads, JMJ, a 26-year-old male who is HIV positive was recently diagnosed with pulmonary TB. JMJ's HIV is controlled on TVK, which contains dolutegravir 50 mg, and Truvada, which contains tenofovir 300 mg, co-formulated with emtricitabine 200 mg, all orally once daily. JMJ's CD4 is 520 cells per millimeter cubed, his viral load is undetectable. His labs are within normal limits. So my question to you is, which of the regimens listed below would be best for treating JMJ's TB during the continuation phase of therapy? Would it be A. Rifabutin 300 mg plus isoniazid 300 mg once daily, or B. Rifabutin 450 mg plus isoniazid 300 mg once daily, or C. Rifabutin 150 mg plus isoniazid 300 mg twice weekly, or would it be D. Rifampicin 900 mg plus isoniazid 900 mg once weekly? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is A. Rifabutin 300 mg plus isoniazid 300 mg once daily. Rifampicin and isoniazid once weekly regimen is not recommended in patients with HIV because of the increased risk of rifamycin resistance, making answer D incorrect. Rifabutin, as well as rifampin, is an option for treatment. Rifabutin does decrease concentrations of dolutegravir but only to a small extent. Dolutegravir does not induce rifabutin concentrations, making a 450 mg dose unnecessary. That makes answer B incorrect, nor does dolutegravir inhibit rifabutin concentrations, making a 150 mg rifabutin dose unnecessary. That makes answer C incorrect. An initial standard dose of 300 mg is therefore recommended, which makes answer A correct. Please progress to the next question. And the next question reads, PLM, a 25-year-old male patient with HIV is given a diagnosis of active TB. His daily TB regimen comprises of rifabutin 150 mg, isoniazid 300 mg, pyrazinamide 1500 mg, and ethambutol 800 mg, while his HAART regimen consists of raltegravir 400 mg orally twice daily plus emtricitabine 200 mg co-formulated with tenofovir 300 mg orally once daily. PLM returns for a follow-up 1 month after beginning his TB treatment complaining of blurred vision. Further testing shows he lacks the ability to detect the color green. So my question to you is, which of the medications listed below is most likely responsible for this clinical scenario? Is it A, ethambutol, or B, pyrazinamide, or C, rifabutin, or is it D, isoniazid? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is A, ethambutol. The most serious adverse effect associated with ethambutol is optic neuritis. Optic neuritis may affect one or both eyes, causing blurred vision and a decline in visual acuity, and can cause a patient to be unable to detect the colors red and green. That makes answer A correct. Rifabutin can cause anterior uveitis, an inflammation of the middle layer in the eye that may also lead to blurred vision. However, the inability to detect green or red is not likely with rifabutin toxicity, making answer C incorrect. Isoniazid and rifampin are not known to contribute to vision problems, making answers D and B incorrect. So there you have it, our highly esteemed viewers and listeners. That brings us to the end of this video. If it benefited you in any way, kindly remember to give it a thumbs up, to like it and to share it widely with your peers. Please leave your comments at the bottom. And if you haven't yet done so, I humbly urge you to subscribe to our YouTube channel. I would like to promise you all that the very, very best is yet to come. Thank you very much for viewing this video. On behalf of our senior colleague, Dr. Nath Arua, I sincerely appreciate your partnership, continued support and kind collaboration. We look forward to interacting with you in the next video, which will be part 172.